Okay, let's resume. Let's go now to heart failure page. Just go down the module. So we did chapter 8 and chapter 41. Let's now go to perfusion chapter 30, page 585. Heart failure is not a simple condition. This is actually a state wherein, by definition, this is a state wherein the heart doesn't work effectively as a pump. The heart's job mainly is to keep pumping, to oxygenate the blood, because the right ventricle pumps blood to the pulmonary circulation, and then it returns to the heart on the left side, and then from there the heart pumps oxygenated blood to the aorta and for systemic circulation. Now let's review this. Frank Starling. Who remembers Starling's law? Thank you, Miss Omo. You remember Starling, your friend Starling?
Yes.
What did he say about his postulate? You know, his theory.
I don't remember his theory, but from what it says the contractibility of the myocardial muscle is influenced by the amount of blood within the ventricle prior to systole.
Okay, very good. So his how I remember Starling is about the rubber band. So he always talked about the stretching of the myocardium, specifically the ventricles. So he said that the more you stretch the myocardium, the greater the force of the contraction. So this is his law. So he's talking about preload. Preload is the referring to the volume, meaning the higher your preload, the higher your blood volume. The lesser your preload, the lesser your blood volume. So since the heart is like a rubber balloon, so the more blood you put in there, the greater it will stretch. And just like a rubber band, so the longer you stretch a rubber band, the farther it will go, correct?
Right.
Right. So with your underwear, so let's say, um, is this Richard or is
No,
this
this is
Israel?
Israel.
Okay,
This is
so let's
Israel.
say Israel just bought his pair of G-string underwear.
That's rich. That's
No,
rich.
Nazi.
The garter is very strong. Okay, so he fooled around at home, with his partner. So he used his brand new underwear like a rubber band, stretched it, and then hit his partner with it. Okay, so at that point, the rubber band is brand new. So the heart also in this instance is only stretched a few times. Okay, it's not like stretched every single day. But if Israel continues to do this with his underwear 2 years later, can it still go as far as it used to?
No.
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 No. Now you are overstretching the rubber band. In the same way, if you overstretch the heart, though, it will no longer, the Starling law will no longer apply. Because now here, the heart obviously is dilated. It's no longer going to have as forceful of a contraction as it used to. So you can say Starling's law can work both ways. So occasional stretching is good, but constant stretching of the myocardium also weakens it, because now you have dilated the myocardium, the ventricle specifically, and then therefore weakened it. So once the muscles are now weakened due to overstretching, because you have a high sodium diet, your blood volume's high, you're always stretching the myocardium, so therefore your heart will fail. The other side of it is in hypertension. So let's say your patient's blood pressure is constantly high due to not only the increased blood volume, which increases preload, but the afterload. The afterload is referring to the vascular resistance. Afterload is referring to the diameter of the blood vessels. So, Yan Lu, which straw is easier to sip bubble tea out of it? Or let's say um, Slurpee. Okay, so if you're either drinking Slurpee or bubble tea, which type of straw will be easier to sip it through?
The biggest
A
straw.
coffee stirrer or a wide diameter large straw?
Why damage it?
The bigger straw, right?
Yeah.
Try sipping bubble tea or Slurpee through a coffee stirrer.
It'd be too small.
Yeah, it's gonna be hard.
It's gonna be very hard, right? You're gonna have to sip extra hard in order to get your drink through the coffee stirrer. So in the same way, if your blood vessels are now atherosclerotic due to high cholesterol, high um, high blood pressure, um, through smoking, for instance, all of these contribute to atherosclerosis, right? So once your blood vessels, especially if your arteries are now narrowed, what happens to blood pressure?
It increases because you
What
gotta put
happens
more
to
force.
the workload of the heart?
It increases
Oh,
also.
baby. It
Okay.
increased.
So in both cases here, therefore, if afterload and preload are both increased, then the heart can fail eventually. So that will increase the workload of the heart. It will, and the preload will increase the stretching of the heart muscles, causing dilation, weakens it as a pump. Now you have heart failure. There are two main types of heart failure. We have left heart failure, which is also called systolic heart failure. Then we have right side heart failure, which is diastolic heart failure, or you can have both. The manifestations is easy to remember. All you do is trace the anatomy and physiology of the cardiovascular system. Let's do that right now. So to explain table 30.6, the difference between left and right side. So this is Davian's heart.
Alright.
Okay, so this is her septum.
Apple.
This is her mitral valve, tricuspid valve. This is the pulmonary trunk. This is the mitral valve. Okay. So this is the superior inferior vena cava. So let's trace the flow of blood. So these are the pulmonary veins, and you have the lungs here. So Miss Decker, trace the flow of blood into the lung and into the heart, to the lungs, and then back into the heart, and then out of the aorta.
What do you mean trace it?
Yeah, let's say I'm a red blood cell. I just entered the heart.
Okay.
I'm right here.
Okay.
Okay, so where do I go?
Down. Okay.
Where do I go next?
Gonna go up.
So pulmonary artery to the lungs.
Okay, so I came to the lungs. Now what?
And come back to the left atrium.
Okay, so I go back on the left side, right?
Yeah.
And
you go down to the
Go
left
to the left
ventricle, and then up through the aorta.
okay, back out here. Very good.
I know my heart.
All right, Damien. So you can compare this to traffic, right? So let's say to go from in and out of Manhattan. So let's say the heart is Manhattan, and then this is Queens right here, and this is New Jersey. All right. No, New Jersey is the aorta, let's say. This is, I don't know, Bronx. Okay. So you enter the heart deoxygenated, and then you go to the lungs to get oxygen. You return to the heart oxygenated already, and then you go out again. So if we compare this to traffic, whenever, let's say you're entering Manhattan, so this is, let's say, Queens Midtown Tunnel, and this is the bridge, okay, so let's say Kosciuszko Bridge. So when you enter Manhattan, if there's traffic here, so let's begin with right side failure. Let's say the right ventricle failed. You had a massive heart attack affecting the right coronary artery. So this is now the traffic. So there's a big accident in the which tunnel is this? Queens Midtown and Kosciuszko Bridge. There's some big traffic there, huge accident. The Avengers are fighting some, some big time people there. So there's a war going on. So can traffic flow?
No.
No. There'll be backup. There's a big traffic jam here. So we have a huge gridlock. And now, will the traffic stop here?
Yes.
There will also be traffic in the tunnel and in the bridge. Right? So this will explain, so if there's traffic there, so if now blood can't enter the right side because there's traffic in the right ventricle, so what will happen to your patient? What will be the patient's symptoms? Here, go ahead.
Okay.
Yes?
Jugular vein distension.
Okay, so now your signs and symptoms are because blood cannot enter the right side of the heart. Remember, the bridge here comes from your head. So therefore, if blood from your head cannot drain into your superior vena cava, that's what will, yeah, so you'll have jugular vein distension. And also that's not it. This is a very limited signs and symptoms. So what other parts of the body drains through the superior vena cava?
Your liver.
No, the liver is in the inferior.
The way has
The brain.
What about your shoulders and the upper part of your body?
Your head, your brain.
Yeah, so your head, brain, and your upper extremities all drain there, right? So those are all the edema there. So you'll have neck facial edema or even upper extremity edema, or this is earlier though, you have jugular vein distension. And now on the tunnel side from the inferior vena cava, if blood cannot drain from your esophagus, the rest of your GI tract, your lower extremities, so all of these parts of the body has to go through the liver or the portal circulation, correct? Because the last organ before you enter the inferior vena cava is the liver. So if there's traffic in the tunnel in the inferior vena cava, there will also be backup of traffic and eventually edema in the liver first, hepatomegaly, and then that edema will spill over into your peritoneum in your stomach, so resulting in ascites. So the edema will also spread further to any dependent area now. So you'll have edema everywhere. You'll have edema in the liver, in your abdomen, and in
Mm.
your lower extremities. All right, so are we clear with the right side?
Yeah.
Yeah.
Let's go now to the left side now. So at the lung, at the end, at the other end, which is now at the lungs. So here, the traffic is in the pulmonary circulation now. So there's no problem getting across the bridge and the tunnel. So it's now the problem is now on the left side. So this is your mitral valve, septum. So this ventricle now died. So same thing, the Avengers were fighting crime here. So the huge accident in the left ventricle, it failed. Remember, all the blood entering the left side came from the lungs. So you have the right and left pulmonary veins trying to enter the left atrium. Can they do that if there's traffic here?
No.
No. So there'll be congestion here, and then eventually that congestion will also spill onto the right side. But let's just concentrate on the immediate effects. So immediate effects will be pulmonary congestion. So if on the right side here you had systemic congestion, that's why you had liver, abdomen, and lower extremity edema there because there's systemic congestion. Here you will have pulmonary congestion. So there's traffic in the pulmonary side on both lungs. So that's why what are our signs and symptoms on the left side?
Shortness of breath.
Dyspnea.
Fatigue.
All right. Because remember, the left side does what? If the right side's job is to pump blood to the lungs in order to get oxygenation, what is the job of the left side of the heart? Besides receiving blood from the lungs.
Carry oxygenated blood.
Okay, they're responsible for cardiac output, right? They're responsible for systemic perfusion. So if that's not happening, that's why your patient will go into fatigue. Because there's low cardiac output. So your extremities, the rest of your body will have poor color, weak pulses. And remember, these are only the skin we're talking about. Look at all the organs now not receiving perfusion. So we're talking about systemic now. So you will also have dizziness here, confusion, because there's no oxygen getting to the brain. You're talking about low urine output because there's not enough blood getting to and oxygen getting to the kidneys. So the symptoms here are all about low cardiac output. Plus, you also have symptoms of pulmonary congestion leading to pulmonary edema. So that's why you have the shortness of breath, you have the crackles on auscultation, you'll have pink frothy sputum also because of pulmonary edema, etc. So here it's not very complete, but just use your imagination, okay? Again, we'll summarize right heart failure based on the function of each side. So we said that the right side is responsible for two things. They receive blood from the systemic circulation, and also they're responsible for bringing that blood to the lungs to get oxygen. So if the right side fails, you will have a um, forward flow problem, meaning you have less blood going forward. That's why it results in edema, meaning pooling of water all over the body. And then on the left side, since its job are two things also, one is to receive blood coming from the lungs, and the most important job is to pump that oxygenated blood for that.
Hello?
So you'll have sim-
You're
as
breaking up.
Hello? Yep.
I
Yeah,
can't
you're
hear
breaking up, Professor.
questions.
No,
I
you're
can't.
you're breaking up.
I'm sorry.
You're breaking up bad. We can't really hear
Yeah,
you.
it's saying my yeah, but I'm sure the recording picked it up, so I'll just send the recording. Okay, after it'll be in 3 parts. I'll put them up on iTunes U.
Thank
Okay.
you.
Thank you.
Let's go now to diagnostic test. You remember an item in chapter 8 under regulatory mechanisms, and then I mentioned counter regulatory mechanism, ANP and BNP.
Yeah.
Remember? Okay.
Yeah.
So here, since is heart failure a condition of fluid overload or fluid deficit?
I would say fluid deficit because the blood is not really going throughout the body.
Okay, so if you say overload, I mean deficit, did the patient lose fluid?
No.
No.
Did the patient produce normal urine output?
Yeah.
Because remember, there's not enough blood, there's low cardiac output, therefore there's not enough blood getting to the kidneys. So can the kidneys make normal urine output?
No.
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 So again, is the patient in heart failure in fluid deficit or in fluid overload?
Fluid overload.
Fluid overload.
Again, if the pump fails, the right side job is to receive unoxygenated blood from the systemic circulation, and then the left side job is to receive oxygenated blood from the lungs, and then to circulate it throughout the body. If both sides fail, what happens to cardiac output?
It decreases.
Be a
What
decreased cardiac
happens
output.
to perfusion of the cells for them tissues and organs?
Yeah, so that mean that the kidney wouldn't really get that much blood, which means that it wouldn't really work that well, which means that your urine would decrease, which would cause fluid overload.
Oh, exactly. So the patient here will not have adequate urine output. So are we making 1500 mLs of fluid like we normally would?
No.
No.
No. Since we're supposed to get rid of 1500 mLs of fluid, and then that now drops to about 400 ml per day, what happens to the other 1100?
It stays in the cells.
So
I
is
think it's one who comes up as
Or not the
edema.
cells.
okay. So is the patient in fluid deficit or in fluid overload?
Fluid overload.
We are in
Because the
fluid
symptom of heart
overload,
failure is edema.
right, when we are in heart failure. So remember in chapter 8, we talked about BNP and ANP under counter-regulatory mechanisms. Is there stretching of the ventricular wall here in heart failure?
Yes.
Yes, there is overstretching because it is in failure, right? The ventricle specifically cannot get rid of the blood volume there. They cannot pump effectively. So once the ventricles and the atria are now stretched, what did we learn in chapter 8? That these two, what hormone will they release? Which is
ADH.
ADH.
no, ADH is coming from the hypothalamus. Remember, ADH, renin-angiotensin, aldosterone system are all
Yeah.
regulatory
They
hormones.
release the ANP and the BNP.
Okay, so remember that RAS and the ADH were released in response to low blood volume, low blood pressure. Now we have high blood volume here. So this is now the opposite. So instead of having the RAS and the ADH, what will be released is the ANP and the BNP. But because no other organ in the body releases ANP and BNP, can they be used to diagnose heart failure?
No.
No.
Yeah.
Yes, because no other
Yeah.
can
Yes.
use it.
Yes, making
Yes.
them the only reliable markers to indicate the degree or the severity of heart failure. So the higher the BNP, that means this, and BNP is only released in response to overstretching of the ventricles, and their effects are two, which is opposite aldosterone. So instead of reabsorbing sodium and water, BNP causes diuresis and vasodilation. However, obviously this one is not enough to save the heart. So the patient is now considered to be in heart failure exacerbation or acute heart failure. Heart failure is a chronic condition. So during times that they decompensate, they are called flare-ups or heart failure exacerbations. Because there's really no cure for heart failure. Once you develop heart failure because of various conditions, we look at the different causes that lead to it. You have it for life. All you can do is just to um, maintain medications, maintain cardiac output using medications, and we'll look at the medications next. Question so far?
No.
Professor.
Yes, Richard.
So when do you check for the troponin level?
Okay, troponins is indicating myocardial injury or infarction. That happens in a heart attack when your coronary arteries are blocked. Remember, the heart does not receive perfusion inside it. Meaning, what I'm trying to say is, if this is your heart and this is the aorta, these are the vessels. The coronary arteries are here. This is your right side, right main coronary artery. This is the left main coronary artery. They arise from the aorta, meaning if this is the left ventricle, when blood comes out of the aorta, the coronary arteries don't get any because the blood flow is going this way. Just this during ventricular contraction or during systole. During diastole though, when the ventricles are not contracting, meaning blood after blood goes there, and during diastole blood falls back, blood now enters the right and the left coronary arteries. Make sense?
Yeah.
So now, if one or more coronary arteries are now blocked, so that means the myocardium isn't receiving any blood, then that will lead to ischemia, three levels. One is ischemia, and then injury, and then finally infarction. Infarction is already death of the cell, of the myocardial cell. So it's once they die, then you have your troponins. Troponins are protein released by dead myocardial tissue. Make sense?
Oh, okay.
Okay. So the BNP is different. BNP is released by the myocardium when they are overstretched. So when these are filled with too much blood volume, they are stretched to capacity, then they release BNP. And in the same way, if the atria are stretched to capacity, they release ANP. But we're only concerned of the BNP really because the ventricles determine cardiac output, especially the left ventricle. So if they are overstretched, they will release BNP, giving us an idea of how bad is the stretching, how bad do we, um, how bad of a heart failure state are we having. So the higher the BNP, the worse the patient's exacerbation. Are you with me so far?
Yeah.
Okay, so now let's go to what do we do now? So we draw blood levels of B and P, then we determine, oh, it's pretty bad, it's very high. So the main treatment here is to reduce that blood volume. So we use diuretic therapy in order to decrease the preload, decrease the blood volume, in order for the heart to catch up. Because we have no other heart. We only have one heart. If it's already in failure, what we can do is just assist it. So if heart failure is exacerbated by increased preload and increased afterload, what do we need to do to the preload and the afterload?
We need to decrease it.
Okay, so our medications here that follow are all about decreasing preload and decreasing afterload.
Professor, I have a quick question.
Go ahead.
So, like, if you have heart failure and that means that your kidneys is not functioning properly, so that you're gonna decrease the amount of urine that you're putting out. How can you give them a diuretic? Like, wouldn't the diuretic not really work?
Actually, it works like this. Remember, what's causing the decreased cardiac output here is the increased preload right here and the increased afterload, right? Because
Right.
both will increase the workload of the heart. Once you decrease workload of the heart, once you decrease it, what happens to cardiac output?
It would decrease also.
Decrease.
No. If you decrease the cardiac workload, what happens to cardiac output now?
Oh, it increases. It increases.
You increase it. So now once increased, what happens to urinary
Oh,
function?
oh, now we'll go back better.
Exactly. So the only way here, so the purpose of your diuretic isn't really to improve the kidney. That's an indirect result. Your main
Oh,
result is you're trying to increase cardiac output. Because remember, these are your targets. So since the heart failure was caused by high preload, high afterload, you need to decrease preload, decrease afterload in order to improve cardiac output and therefore restore systemic perfusion. Let's talk about each one, how they work. Um, since the automatic response to decreased cardiac output is the sympathetic system and the renin-angiotensin system, right? These are automatically triggered. The moment cardiac output drops, renin-angiotensin aldosterone system starts to kick in. The adrenal glands also release your catecholamines, sympathetic hormones, which are epinephrine and norepinephrine, right?
yeah.
Are these helpful in the meantime? I mean, if your patient is in a heart failure state, so we are in heart failure, so our cardiac output is decreased. Because this is happening, it will automatically release renin-angiotensin and your sympathetic nervous system, correct?
Right.
So how did we have heart failure in the first place? We had high preload, high afterload, right? This is the beginning. This is what happened first. We went into heart failure, cardiac output dropped. Now we have automatic responses. We will do renin-angiotensin aldosterone system, which is trying to increase cardiac output. Same thing here is trying to increase cardiac output. What this does though, this will increase preload some more. This will also increase afterload some more because remember this is renin-angiotensin causing vasoconstriction. And this is aldosterone which causes sodium and water absorption, thereby increasing preload. This one also increases heart rate and causes vasoconstriction, causing increased afterload. So in short, are these two guys helping the situation?
No.
No. So in this case of heart failure, we want to stop this guy. We also want to stop this guy because they're not helping. They're increasing preload and afterload. So now our treatment now involves what drugs? We now give ACE inhibitors because this will stop the renin-angiotensin system, right? If the patient can't tolerate that because that causes hacking cough, we can also use angiotensin receptor blockers instead. They work the same way. We also give them beta blockers to stop the sympathetic response. Where is beta blockers? He should be here. Right here. So we give beta blockers to stop the sympathetic response. Okay, and then we have ACE inhibitors to stop the RAS, and of course to further decrease preload. Somebody said earlier diuretics, so we can use furosemide. So this will make the bulk of your therapy. So we want to, and then finally contractility here. Contractility though is you only use to, digoxin is only used in chronic heart failure. It's not really helpful in, sorry, I'm just trying to see right here. So our drug therapy therefore must be in order to decrease preload, decrease afterload, and then increase the contractility. So the digoxin here, again, is only used in chronic heart failure in order to increase cardiac contractility. All right, and here is a even new information here. Currently, doctors are questioning the use of digoxin because when we go to the dysrhythmia chapter, it's actually associated with a lot of braided dysrhythmias, including heart blocks. So, however, it's not totally eliminated from the treatment of heart failure yet. I mean, right now, we're still using digoxin, but this is just simply telling you that some doctors are now exploring other treatments. They're trying to eliminate digoxin in the treatment of heart failure because of the what is this? These harmful side effects that it is causing. Not to mention digoxin toxicity. Are you with me so far? Okay.
Yeah.
So if we do and this will be the end of the day. If we do a summary, um, how do I? Okay, so here if we do a acronym, no, not B, D, do doables. So here we have diuretics, we have digoxin, this is oxygen, of course, and this is ACE inhibitors or angiotensin receptor blockers. We have beta blockers, We also have BNP because we can drug Nesiratide, or this is Natricor. This is BNP also. This is not drug. This is low sodium diet, and this is exercise, and this is stop smoking. These are the mainstays. Of course, these are only the drugs here. These are non-pharmacologic. So non-pharmacologic treatment. These are your pharmacologic treatment for heart failure. So we give diuretics, digoxin again only for chronic heart failure. But during the exacerbation, these are your drugs mainstay. Diuretics, oxygen of course, and then your ACE and ARBs, beta blockers. This drug is also given, but this is very expensive. So this is it. We have, of course, other drugs, but those are now reserved for really critical heart failure patients where they're going into shock already, cardiogenic shock, and that's a different chapter already. So we'll discuss if this patient in heart failure goes into cardiogenic shock, then that's a whole different list of medications again. Any question?
No.
So again, just remember, this is our problem in heart failure. So this started the whole thing. The patient went into, there were conditions that led to increased preload and afterload, thereby the heart failed. Now our cardiac output drops, which automatically stimulated the two regulatory or compensatory mechanisms, which are not helpful. So we need to suppress them with our drug therapy. So the same things that led to the heart failure will be the same things that will be targeted by your drug therapy. So diuretics obviously decrease preload by removing water. ACE and ARBs stop the renin-angiotensin system. So we have the opposite. Therefore, this one will, instead of reabsorbing sodium and water, so you'll have loss. So in a way, this will cause decreased preload. And it also has a vasodilating ability because remember, RAS system causes vasoconstriction, right? So if you stop it, then you'll also have vasodilation. So therefore, decreased afterload. Beta blocker stops the sympathetic nervous system. So therefore, instead of vasoconstriction, you also have vasodilation leading to afterload. And at the same time, it will, instead of the sympathetic nervous system increasing heart rate, beta blockers decrease heart rate. So therefore, all of them decrease the cardiac workload, improving cardiac output, etc. All right, that's it. So we'll continue next week. Your quiz will be on chapter 8. What chapter was diabetes insipidus? 41?
41.
Yeah, 41 and 30. Not
Those are
really
for the
30,
quiz.
right? So chapter 8, 41, and chapter 30.
Those are for the quiz, right?
Yes, quiz next week, 10 items.